Monsour, who is a headache neurologist and director of the Axon Institute for Headaches and Neurological Sciences in Oakville, Ontario. He's also a consultant neurologist, and he's involved as our headache neurologist at our local UHN Intracranial Hypotension Program. And he's going to give us an introduction to SIH.
Thank you to the organizing committee for inviting me to speak and get this conference underway. This is a great honor and privilege, especially in front of all my esteemed colleagues and peers. So I believe, will the slides be forwarded by the AV team, is that correct?
You should already have the proper slides up. Yeah. Oh, just use the green button.
Perfect, thank you. All right, so without further ado, let's get started. So these are my disclosures. The only relevant one here is that I'm a member of the Medical Advisory Board of Spinal CSF Leak Canada. And so what is a spinal CSF leak? What is spontaneous intracranial hypotension? So defining it's relatively important. So CSF leaks happen when CSF escapes the intrathecal space, resulting in a decrease in intracranial volume. You'll see time and time again throughout this conference that not necessarily low pressure is the etiology, but potentially low volume. And leaks can be classified as either spontaneous or secondary. We'll be focusing mostly on spontaneous intracranial hypotension, so arising without any known trauma or medical intervention. Secondary causes, just for example, could include things like trauma, surgical procedures, lumbar punctures, or spinal anesthesia. When you look at the epidemiology, it certainly is underrepresented. You know, there are cases of individuals who may walk around with a spinal CSF leak that may not even seek medical attention. I was talking with Dr. Shavink, and he was mentioning, you know, there's the potential of you having transient intracranial hypotension periodically throughout your life, and you may not even know it. And so the estimated occurrence here is approximately 3.8 to 5 cases per 100,000. Interestingly, it's comparable to MS and ALS. So why is it underdiagnosed? Why is it underrepresented in our educational models for medical students, residents, neurologists? Is yet to be elucidated, but certainly we're trying to bolster that education around this subject so that individuals will not be missed when they're seen in a clinical setting. And when you look at reasons why it's underdiagnosed, potentially it could be nonspecific symptoms, you know, historically low imaging sensitivity, but certainly it more or less is dependent on the reader of the imaging and understanding what to look for, right? If you don't know what you don't know. And misdiagnosis, right? A chronic daily headache can be misdiagnosed as migraine, new daily persistent headache, or in unfortunate circumstances deemed psychogenic or non-organic. And when you look at why individuals present with the symptoms that they do secondary to CSF leaks, we think of this doctrine called the Monroe-Kelly doctrine. So Dr. Monroe and Dr. Kelly put together this doctrine that essentially establishes the following. The skull, the intracranial cavity, is a constant compartment, and it's a fixed volume compartment. It's composed of 3 volumes: the brain, the blood volume, arterial venous, and the cerebrospinal fluid. So, in theory, if any of those decrease, the others have to compensate. And so, total intracranial volume must remain constant, and a decrease in CSF could be offset by increase in other compartments. So, for example, when you are leaking, you get venous engorgement. So that's a compensatory mechanism secondary to this theory. And though often taught as a static issue, it more or less is a dynamic doctrine. So things such as venous outflow play a big role in the development of intracranial compartment pressure. So when you have a spontaneous intracranial hypotension, CSF volume drops, and then as I mentioned, there is compensatory mechanisms, so venous engorgement, you have subdural fluid collections, and brain sagging. And then these changes underlie the classic MRI findings that you see on imaging. And you know, the SEEPS mnemonic, which will be talked about in detail today, aligns with this principle. So what patient characteristics and triggers and what comorbid disorders should you look out for in the initial clinical assessment? Well, it is gender biased, so it's a 2-to-1 ratio female to male. It typically presents in individuals mid-age, so around age 30 to 50. And there may be or may not be a precipitating event. Most of these events are relatively trivial. Could be things like lifting, exertional triggers, going on a roller coaster. And activities such as Valsalva could also precipitate this. doesn't necessarily have to be a dramatic trauma. And when you look at other underlying conditions that you want to sort of screen for, essentially, in your assessment, so think of connective tissue disorders, Ehlers-Danlos syndrome, a vast spectrum of connective tissue related issues associated with this disorder, Marfan syndrome, and autosomal dominant polycystic kidney disease as well. Associated findings, you may see individuals who present with suspected connective tissue disorders, with intracranial vascular abnormalities. They may present with cardiac abnormalities. And so as a clinician, when you're confronted with this patient, consider investigations to screen for these things. So for example, angiography of the brain, for example, non-invasive echocardiography. And furthermore, degenerative spine conditions can also precipitate a spontaneous CSF leak. So osteoarthritis, vertebral osteophytes, and calcified disc herniations. These may erode the dura, causing these CSF leaks. And so when we classify a spinal CSF leak specifically, we identify it based off anatomical localization, but it's also broken down into these four subtypes. Type 1 is described as a ventral dural tear. So the dura, for a multitude of reasons, most commonly a calcified disc or osteophyte, will over time erode, get irritated, and eventually tear, leading to what we see on spinal imaging as an extradural spinal fluid collection. The type 2 leak is a lateral dural tear, more proximally, and so you also see the spinal fluid also collect around the spinal cord in these instances. So the type 1 and type 2, which will also be described in more detail in the radiology sessions, is what we deem a spinal imaging positive subtype. Not always the case, but most often than not. The latter two, so type 3 and type 4, so type 3 is what we call a CSF venous fistula. The CSF is depleted and diverted through an abnormal fistula into the paraspinal veins. And then a type 4 is a distal nerve root sleeve tear, whether or not it's due to dural weakening from a diverticula or other reasons. So these are deemed, generally speaking, a spinal imaging negative subtype, because basically the spinal fluid is deviated elsewhere and it can't be picked up on conventional imaging. There are less common leak mechanisms that have been reported, so dural ectasias, what we call sacral dural tears linked to Tarlov cysts at times, and then even rarely CSF lymphatic fistulas. And I certainly think that imaging this is quite challenging, but it has been reported. So let's talk about the clinical features. When you're assessing a patient with a suspected CSF leak, what are you looking for? Well, conventionally, it's a headache. And so let's talk about the headache features. The headache associated with spinal CSF leak occurs in the vast majority of patients, upwards of 90–97%. And when you hear about the onset, it can be gradual, it can be chronic, and it can also be thunderclap. So thunderclap, by definition, is a headache that goes from 0 to 100 within 60 seconds or less. And for all our trainees here and those who are learning about headaches and neurology, whenever you're confronted with a patient with thunderclap headache, always put spontaneous intracranial hypotension on your differential diagnosis. So what is the classic headache? The orthostatic headache. We talk about this orthostatic headache as the most bothersome symptom. I'm borrowing terms we use in migraine. So the most bothersome symptom in this disorder is the orthostatic headache. And it presents in upwards of 90% of individuals, but not everyone. So that's important. It's worse when upright, relieved by lying down. And when I assess patients, I'm not so fussed about how severe it is when you're upright, but more focusing on how well do you feel while flat. So what happens when you immediately lie down, or when you're in a prolonged supine state? How much improvement do you see? You know, I use a gauge of 50% improvement within a short duration of time is meaningful enough for me to think that there's an anatomical reason why they're having this orthostatic headache. Now, it doesn't necessarily have to go down to 0 either. So just keep that in mind as clinicians. If they don't have complete resolution while flat, it doesn't necessarily rule out an SIH in a clinical setting. What we often hear is this sort of progressive headache, best in the morning, worse later in the evening. So this sort of later in the day headache, and that's classical for SIH. Now, keep in mind, this may fade over time. You may be seeing these patients years later. They may convert to a chronic daily headache. They may lose their orthostatic pattern. And why that happens? Well, there are mechanisms within our brain that can sensitize nerves. If you have a prolonged, let's say, brain sag and prolonged venous engorgement leading to these mechanoreceptors being sensitized, they may just be permanently turned on. And so you develop the sensitization, and then eventually that orthostatic pattern disappears or it becomes less and less, let's say, noticeable. So to continue on with headache features, we talked about how they're usually chronic and daily. We talked about the pattern at which you see these headaches. But the quality is also very distinct at times. The patient will describe, it feels like somebody stepping on the top of my head, a pulling sensation. And sometimes that pulling sensation radiates through the occiput, suboccipital area across the shoulders and across the shoulder blades. And if you ask them, does it feel like a coat hanger pulling down the back of your head? Some of them would say yes. And so you have this description of a coat hanger distribution of pain in some of these individuals. And so that's something to also screen for as well when looking at the quality of pain. Interestingly enough, exertional Valsalva-induced headache, although seen in other conditions, can be seen in SIH. In the absence of any spinal imaging abnormalities and the presence of Valsalva maneuver, there has been an association with this being suggestive of CSF venous fistula, but it can present in various subtypes of spontaneous intracranial hypotension. Very rarely, it can be a paradoxical presentation wherein the headache is worse while flat versus upright. Certainly it's rare, but just keep that in mind when seeing these patients, especially if the imaging is suggestive. The pathomechanism of pain, I'd mentioned that a couple of times already, but CSF loss leads to brain sag, and then you get traction on the meninges, on the surrounding vessels, which are covered in these nerves that induce nociception. You also get traction on various cranial nerves and other structures within the brain, and I'll describe the non-headache features in a moment that are secondary to this traction. And then you get the venous engorgement and mechanosensitive receptors that get stimulated and then induce this pain sensation. And when you remove gravity, most, in the early stages, most of these changes anatomically reverse, hence why you see an absence of pain or a reduction in pain while flat. So what are the non-headache features? This is what makes SIH challenging, is that it can have a myriad of presentations, a myriad of different presenting symptoms. I broke it down into the following. So cranial nerve palsies, think of cranial nerve 3, cranial nerve 4, especially cranial nerve 6, quite susceptible to traction because it has a long trajectory. Interestingly, I saw a case recently where they presented with abducens palsy on the left, and the imaging, the contrast-enhanced brain imaging, did show slight enhancement of the 6th nerve, which was suggestive of a neuritis, to a sort of proof of concept of our theory that there was traction on the nerve. Vestibular symptoms as well, which are very prevalent, and I'll talk about that in a moment, but you can present with pulsatile, most commonly non-pulsatile tinnitus, hearing loss, vertigo, oral fullness, which means ear fullness like you're on an airplane. An altered level of consciousness and coma, certainly in severe cases when there's subdural collections or interruptions to the reticular activating system. You can present with cerebellar signs, ataxia, etc. Frontotemporal dysfunction, this will be elaborated further in today's conference, but you can present with apathy, behavioral changes, and to all my clinicians here, don't forget about behavioral variant frontotemporal dementia in SIH is a reversible dementia. It's one of the few reversible dementias out there. And you could present with movement disorders and a rare bibrachial amyotrophy, which will be talked about further today. So to delineate between the vestibular and cognitive symptoms, vestibular and auditory symptoms are fairly prevalent. Most individuals with SIH may present with dizziness, vertigo, about 50% of the time. They may present with balance disturbance, disequilibrium. Muffled hearing, I hear, and ear fullness is something that I hear often about in my practice. Tinnitus, hyperacusis, hypoacusis, so hearing loss, sensitivity to hearing. And once again, these are secondary to traction. And when you look at the variations in cognitive presentations, the most common complaint we hear about is this mental dullness, quote-unquote brain fog, quote-unquote difficulty with, let's say, short-term memory, word-finding difficulties, concentration, and behavioral changes can happen as well. In severe forms, we had talked about BVFTD, and that will be elaborated further later on. So when we look at our assessment recommendations for suspected spinal CSF leak and SIH, what should we look for? And let's break it down in detail. So when you're presented with a patient with SIH, what should you identify? Well, one, you want to identify, is there a headache present? Certainly, is it orthostatic or not? Is it thunderclap or not? The non-classic types are also relevant here, so don't forget to take a detailed headache history, including location, quality, precipitating factors, associated features, triggers, etc. We want to talk about onset, so anything that may have triggered off the onset of this presentation, whether or not it's trivial trauma, whether or not it was more significant trauma. Try and nail down the details about the onset, because that will be the answer to the presentation. A lot of the time, individuals come to your clinic and they've been seeing multiple providers, and it's been years, and it can be quite difficult for them to articulate, how it felt at the beginning. But try and see if you can rejig their memory about the onset, because I believe that truly is where a lot of the answers lie. Don't forget the other symptoms. So we usually take a comprehensive history for our evaluations when I see patients, from cognitive history to vestibular cochlear history. We talk about cranial nerve palsies. We talk about cerebellar symptoms and signs such as incoordination, ataxia, etc. And then you expand your past medical history to talk about things that may be relevant. So whether or not it's connective tissue disorders, whether or not there's a family history of connective tissue disorders. You want to think about a history of Chiari-1. Was there any baseline imaging done prior to this person being seen in your clinic? For example, at times, if they have had imaging for other reasons in the past, this may be an opportune time for you as a provider to sort of go back in time and do a quick overview. Look at this imaging before their onset and see if there's any differences, post-onset as well, that could suggest that this has an SIH presentation has developed as a result. And we hear time and time again of individuals being diagnosed with Chiari-1 malformations and then receiving posterior decompressions. Unfortunately, just due to the sort of an absence of understanding of a broad presentation of why the cerebellum can descend through the foramen magnum. So if you're confronted with a patient coming to you being referred for Chiari-1 malformation specifically, always do a deep dive on the history. Make sure you do full neuroaxis imaging in the right clinical context to make sure that doesn't get misdiagnosed. And talk about the disability. How is it impacting their life? Making sure you establish a foundation of understanding the person behind the condition, because it's going to be a long journey. You're going to be with them throughout the whole process, hopefully. And, it really is a personal condition. At least in my practice, I try and make sure that I capture as much history as possible, because I essentially tell my patients, you're my forever patient. So when I see a patient for the first time with SIH, I'm seeing you for the rest of your life, because I have to make sure it doesn't happen again. I have to screen things, and so we certainly try and establish a nice rapport as a result. So beyond the clinical history, the exam is important. So you're going to look at focal deficits from cranial nerve 3, 4, 6 palsies, for example. I don't routinely do any comprehensive cognitive testing unless the patient presents with such symptoms. I may do a Montreal cognitive assessment. I may do an MMSE, but it's primarily based if the patient is complaining of these memory complaints. Movement disorders as well, so don't forget that. And when you look at cerebellar signs and vestibular cochlear symptoms, there's a lot of overlap there. So things like ataxia, looking for nystagmus, looking for appendicular dysmetria, dysdiadochokinesis. I always do an orthostatic vitals as well. We're going to expand on the differential diagnosis for orthostatic headache, orthostatic intolerance later on in this conference, but checking for orthostatic vitals is important, looking for a presentation of coexistent dysautonomia, or is the dysautonomia the main presentation here? And what I mean by that is postural orthostatic tachycardia syndrome and conditions similar to that. And then when you look at systemic clues, there are certain, let's say, scoring systems. Judge them how you may, but certainly there are validated scoring systems that are available for clinicians to follow if they suspect, let's say, connective tissue disorder. If you're able to click on the hyperlink for Baton score just quickly. If you just scroll over to Baton score and just press on a hyperlink to one of the slides. if you have a mouse there. Perfect. So it's just a quick way. It's not certainly diagnostic, but it assists in the diagnosis of someone with connective tissue issues or hypermobility, or it just gives a brief overview of susceptibility to hypermobility. Now, I have like 3 or 4 of these myself. I don't necessarily have a hypermobility spectrum disorder, but it's one of those things where it can add to your clinical clues. Let's say if you're suspecting this condition. You can press the back arrow there to go back. Oh, there was like an arrow there that I hyperlinked to go back to the original slide. That's okay. Keep going. There we go. All right. Awesome. And I won't do the hyperlink thing for the Marfan's, but essentially there's also slides there on Marfan syndrome and the spectrum of presentations there. So you can review these slides. I believe they are going to be published, so you can review those at your own leisure. Now, lastly, systemic evaluation. I'd mentioned this briefly. I don't think it's mandatory, but I think just consider. If you're confronted with a patient with suspected SIH who has some semblance of a connective tissue disorder, I'd recommend at least doing general screening for intracranial vascular abnormalities and potentially valvular disease, aortic root dilatation, etc., with non-invasive echocardiogram if the clinical situation deems it appropriate. So, the last couple of minutes here, just to sort of review our key learnings. So SIH is a treatable cause for secondary headache, often due to a spinal CSF leak. So it's doubly important that we teach our residents, our medical students, our non-specialist providers to at least think about this condition. Because if you direct these individuals to the right care as fast as possible, that is where the best outcomes result from. And certainly that's easier said than done, because even when they're identified, who to send them to is still a challenge. And I think in Toronto, at least, we're trying to create a centralized referral system. We're trying to create a centers where there are multiple disciplines involved to care for these patients. And so I'm hopeful that, over time, these programs grow and other individuals identify these patients early and start filtering them to our clinics so we can at least provide them with the comprehensive care they need. And once again, just not to forget that this is most common in women aged between age 30 to 50, frequently underdiagnosed due to multitude of reasons, myriad of presentations, the variability in symptoms, and the misdiagnosis of migraine and NDBH, for the most part, because it's not thought of. Think of the risk factors. So connective tissue diseases, dural weakness for whatever reason, significant spinal disease. Precipitating events may include minor trauma, Valsalva maneuvers. And when you're looking at the imaging, I always use this as a sort of exercise that I do with every patient, is I think of the Monroe-Kelly doctrine to some degree whenever I'm seeing these patients, whenever I'm looking at their imaging. So think of this doctrine when looking at the imaging for brain sag, venous engorgement, just to sort of rationalize what you're seeing. And they don't always present with orthostatic headache, so don't forget that, but the majority of patients do, but symptoms can vary. And like I mentioned, early recognition and structured assessment are key to the diagnosis and management. So hopefully, it was 20 minutes, quick overview of assessment. Hopefully it was helpful. Hopefully it now allows you to go back in time, and some of our providers here, maybe I think of a patient now that I'm going to bring in for a follow-up to reevaluate their case based off what you've learned in this conference this weekend. So I'll end my talk there. There we go. All done. Thank you.